It's my distinct pleasure and a very easy introduction for me to introduce Tom Dunlap, who really doesn't need much introduction. Tom did his undergraduate work at the University of Santa Clara. He graduated from the University of Southern California in medicine, and then he did his residency and fellowship training at the University of Michigan in cardiology. He's been here since 1981, and he's a fixture of the medical community. Along with his partners, Pat Coleman, local emergency physicians, and Tom, they've been instrumental in putting together a STEMI program that really is emulated throughout the state. Tom is my partner in the regional referral program in terms of being the cardiology regional referral director. So with no further introduction, I'd like to welcome Tom. He's going to talk about cardiac health and rehab. Thank you.
Thank you, Chuck. Can you, yeah, I'm broadcasting, okay, good. So we're gonna switch gears here a little bit from the high-tech things that we've been hearing about to a little bit lower tech, and that may be surprising for some of you that know me, that I'm a pretty high-tech guy involved in a lot of innovative interventional type treatments for heart disease. But what I want to talk about today is really more the basic tenets of the management of cardiovascular disease and the issues surrounding cardiovascular wellness. This is generated from my involvement in the cardiac rehabilitation program. We've been very privileged and fortunate to have a superb cardiac rehabilitation program here in Santa Rosa that developed many years ago. And so part of my talk revolves around the activities that we do in cardiac rehabilitation, and then the application of that information, of those findings, of the results of that to your practices and to our practices. That's why I call this practical magic, because it's really very simple things that methods that are straightforward that give us a really excellent outcomes. It's an important, I think, part of what we do, the interactions directly with our patients, that one-to-one contact, and the interactions of our patients with other individuals in the community that help foster good cardiovascular health. So let's just put things in perspective for a moment and talk about cardiovascular disease in our society. If you look at why people die in this country, firearm-related homicides in 2012, as an example, amounted to about 24 a day. Motor vehicle accident deaths in the United States in the same year amounted to about 90 a day. Myocardial infarctions in our country are about 2,700 a day, and with about a 90% survival. Out-of-hospital cardiac arrest is right around 1,000 victims a day with just 10% survival. So cardiovascular disease still remains the #1 cause of death in our country, and the major cost to us both in personal and economic loss. So we've gotten really good at treating the end stages of the disease: ST elevation, myocardial infarction, complex multiple vessel coronary disease, and valvular heart disease. We do over 200 STEMI interventions here in Santa Rosa a year, and we do over 350 open heart surgical procedures here a year. Those are done with less than a 1% mortality rate, and our STEMI mortality rate is less than 8%. So we do a really good job with that. However, in thinking about cardiac wellness, our treatment of patients who are at risk for cardiovascular disease and who have already demonstrated cardiovascular disease, we need to focus more on the goals of identifying these risks and to support treatment for them. The secondary goals that are important as we go forward to these patients is to help them regain mental and physical autonomy and promote and improve but through promotion of improved physical activity. This is an important community health initiative. So this is not a new concept, and very much revolves around the interaction between you, the primary caregivers, and your patients, as well as the cardiologists and other specialists, in educating the patient, giving them access to counseling, behavioral strategies to promote health, healthy lifestyle changes, and modify their risk factors. A historical perspective on the treatment of patients who have manifest cardiac disease. If you go back a couple of centuries, Heberden was the first to describe the symptom of angina pectoris. 4 years later, he and some of his associates presented a case study that showed the benefits of exercise in helping angina. So even a couple of centuries ago, they were learning a little bit about this. Herrick, at the beginning of the 19th century, published the first kind of clear description of myocardial infarction. His treatment for that was recommended was bed rest, and that went on for a long time and reinforced what really turned out to be an incorrect attitude. In the 30s, bed rest still was a more prominent part of the management, but later on then people started seeing that there was a benefit to physical activity. And this became very well outlined in the late 60s through a series of studies that I've listed here, and fostered by greats in cardiology, including Naughton, Sarnoff, and Braunwald. 1976 really saw the explosion of coronary artery bypass surgery. So there were a lot more patients now being recognized as having significant cardiovascular disease and undergoing intervention. 1982 is when the cardiac surgery program began at Santa Rosa Memorial Hospital. At the same year, we also began the treatment for myocardial infarction with thrombolysis. Shortly after that, we initiated the treatment program of angioplasty for acute myocardial infarction, and things have progressed from there. The cardiac exercise program began here in 1983, and initially, some of you I'm sure remember, there was an unmonitored informal program. There was ad hoc physician participation, but it was really the foundation of our current program. In 1991, this became more formalized. We developed a location for it in our adjacent to our Northern California Medical Associates office on Mendocino Avenue, and in conjunction with Santa Rosa Memorial Hospital and some great nurses, we began the program. And this was initially started by Jim Price and a number of nurses, and then went on from there. And it's been a very successful program, highly recognized, and one of the best in the state. So, what do we get out of fostering cardiac rehabilitation and cardiac wellness? One of the primary goals is through the enhanced psychosocial well-being of the patient. It incorporates exercise and the interaction with staff and their peers. This has been well proven on many studies to combat depression, stress, social isolation, and the complications of PTSD. We don't generally ascribe PTSD to our cardiac patients, or have in the past, but it is a real problem. And any traumatic event that involves threatened death or threat to physical integrity with a response of intense fear, helplessness, and horror can initiate PTSD. It's not something that's just in our unfortunate veterans. So the secondary objectives are to try and control the modifiable risk factors. Smoking cessation, increased cardiorespiratory fitness, vascular conditioning, decrease in body fat, lipids, blood sugar, and enhanced psychosocial well-being and ongoing medical surveillance. It's interesting and important to consider what's happened around the world using these well-defined objectives. There have been a number of studies in the last 2 years that have demonstrated that the interaction of individual patients in a peer group setting for the management of risk factors have been much more successful than self-managed. There was a recent study in the Journal of the American College of Cardiology, which is called the Spanish 50-50 study, that very carefully studied this. They applied a set of criteria called the Fuster-Biwott criteria, and I won't explain all of what that is. It's reasonably complicated, but it looks at 9 parameters of health habits and biologic change. And the structure of this study was very simple. They simply took people at risk for cardiovascular disease and people that have had manifestations of cardiovascular disease, whether it be stroke, heart attack, or congestive heart failure, and combined them in groups. They established one person as a group leader, and these were people from various neighborhoods and similar socioeconomic backgrounds. And they ascribed a program of exercise, gave them literature and help in terms of trying to control dietary changes and management of medications. And those people demonstrated a 4-fold improvement on the very set parameters of the Fuster-Biwott scale compared to the self-managed group. So it was a good demonstration of the importance of a group interaction, of support, of person-to-person support in this setting. And that translates over into what we do in our offices. So here you are, you're in your office, and if you look at the data about primary care office visits, recently in that great medical journal, USA Today, there was a report on what actually came out of the NIH, and primary care physicians are spending about 11 to 15 minutes with a patient, and that's pretty common. And the amount of time that a patient is allowed to speak averages between 23 and 30 seconds. So think about that for a moment, and then think about, okay, doctor, let's try and educate your patient. So ready, set, go, here comes the 15-minute clock. Mr. Jones, what do you have to say? Okay, thank you, I'm glad you said that. Here's what I want you to do. So after you've reviewed medications and maybe examined him, maybe actually put your stethoscope on him and listen to him, that doesn't leave a lot of time for other things. So what do? Well, you don't call that guy, you call these people. We're fortunate in our community here to have an organization that is really centered around the patient's well-being, developed to assist us in professionally guiding our patients in the management of their risk factors. Part of this program is this program. This is our cardiac exercise program, and it's a great resource to our community. Unfortunately, we don't have this resource to spread to all of our larger outreach of communities, the 8,000 square miles that we all take care of that I talked about earlier, but it still can serve as a resource for that if we use things properly. Unfortunately, even in our own communities, cardiac rehabilitation is underutilized. We have not really done as good a job as we could. And this is not just a local problem, but this article from the Journal of American College of Cardiology just points out those issues. The cardiac rehabilitation is a Class 1B indication in patients with heart disease. But again, we're not availing our patients enough. So here we have a 1B, class 1 recommendation, level B of evidence, which is for exercise, which is comparative to smoking cessation, blood pressure control, and a meta-analysis indicates that it's dose dependent. The more people do, the better they are. Let me diverge for a moment and talk a little bit about blood pressure control. We heard some comments about it earlier in the context of stroke. In the last 24 months, there have been the publication of two very good studies, one called the ACCORD study and one called the SPRINT study, that looked at where we should be trying to adjust blood pressure. Now, the issue with both of these studies is that they studied blood pressure control in patients that are at high risk. So these are patients with other comorbid conditions. Their age was greater than 50, and in the SPRINT trial, they allowed a blood pressure, their intention to treat was a blood pressure that exceeded 130 systolic. And in the ACCORD trial, their intention to treat was a blood pressure that exceeded 140. In the ACCORD trial, the intention was 140 with the goal to reduce below 130 or down to 130, and in the SPRINT it was 130 with the goal to reduce down to 120. Clinically, there wasn't really any difference between the outcomes in those two groups. They didn't specifically zero in on any one type of treatment process other than the standard actions of appropriate medical therapy according to ethnicity, combining very modest exercise and dietary restriction of sodium. But that's kind of where we are. That's the state of the art of blood pressure management, at least in the high-risk population at present time. So participants in cardiac rehabilitation in patients with coronary artery disease demonstrate significant improvement. Compared to the control group, there's a 12% relative risk reduction or absolute risk reduction and a 56% relative risk reduction in all-cause mortality in patients who've suffered myocardial infarction. In patients that have had coronary bypass surgery, there's a 39% relative risk reduction, and people that have undergone angioplasty, stent intervention, 45% reduction, and in people that have just coronary artery disease, angina, 13% reduction. The interesting part of this is the participation rate is only 13% in potential patients that have had myocardial infarction, 31% in patients that have had bypass surgery, 21% in angioplasty patients, and 19% in patients that have coronary artery disease. So this is where we can obtain some significant improvement. It just shows that we're underutilizing this strategy. How does it work? What are the cardioprotective effects of regular physical activity? Again, this is something you can promote in your patients. You don't need to send them to any facility for that. It's just, again, an education that you can do. And what it does is, in terms of it being anti-atherogenic, it improves lipids, lowers blood pressure, reduces adiposity, increases insulin sensitivity, and decreases vascular inflammation. Psychological benefits include decreased depression, decreased stress, increased social support. Antithrombotic effects include reducing platelet adhesiveness, increased fibrinolysis, decreased fibrinogen, and decreased blood viscosity. Anti-ischemic, it reduces myocardial O2 demand and consumption, increases coronary flow, reduces endothelial dysfunction, and increases nitric oxide production. Antiarrhythmic includes increasing vagal tone, reducing adrenergic state, and improving heart rate variability, all things associated with much better long-term outcomes. So the components to that are required for a cardiac rehabilitation program and include that it's prescribed by a physician, that we document how risk reduction is carried out, that there are psychological assessments including mental and emotional, functional, family, home situation, outcome assessment, individual treatment plan, and the potential to have a home program. These are results from our last year, and I'm not going to go into great detail about this somewhat busy slide, but just note the title headings here that are looked at in each patient. Knowledge about knowing when and why to call a physician, know how to minimize risk factors, your behavioral issues of have you gained confidence in your ability to exercise? Have you tried to make it easier to accomplish this? And these are the targets, and these are the results. And uniformly, the results are better at all levels. We do a quality of life measure called the Dartmouth survey, which includes fitness, feelings, amount of daily activity, social support, quality of life, impression of health status, change, current overall health, and bodily pain. You'll notice many of these things are not necessarily hard physiologic findings, but really more subjective findings in terms of how the patient feels about having a disease. And the lower the number, the better in the quality in the Dartmouth survey. And the patients that participate in our cardiac rehabilitation program have a 19% reduction, which is improvement, based at the termination of their commitment to the program compared to when they start. Another measure is the heart disease quality of life measure, which a higher number is better. There's an 11% improvement in patients that go through the program, and this is based on actual symptoms, ability to function physically, as well as mentally, and quality of life indicators. So everybody goes through these questions and answers, and all of this is documented. So we have really hard data to support the importance of this. Now, how does this translate into, you know, what you do with your patients? Well, it's really clear, and this isn't a new message, but it demonstrates how important it is to encourage your patients to engage in physical activity. The more physical activity that they are able to do, whatever it is, the better it is. The World Health Organization recommendation for physical activity is a minimum of 150 minutes per week of modest physical activity. So that's modest physical activity is walking, and the World Health Organization's recommendation is that. Here are some additional outcomes that have to do. We talked about the Dartmouth study, and this I summarize on this slide, where we demonstrated that there was a 81% reduction in blood pressure in all comers below 150/90. We didn't use a quarter sprint data for this. This has been chosen through the American College as part of the foundation of the tenets of cardiac rehabilitation. Body composition, as measured as body fat, reduced by 4%. That's really quite significant. MET level, 11% of the patients exceeded MET level 5. 38% doubled MET level from entrance into the program, and 62% improved overall. And one MET level is the oxygen consumed by the individual at rest. So applying the principles of cardiac rehabilitation to daily practice of medicine, it's all about trying to be a coach. Trying to help your patient create a clear path to address the things that we can control. And again, these are time issues in the interactions between you and your patients. Things we cannot control. One of the things we cannot control is ethnicity. One example of this is Southeast Asians. The incidence of coronary disease and vascular disease in Southeast Asians is tremendous. It's estimated 60% of the world's heart disease is amongst Southeast Asians. I was stunned to look at that statistic. And this is based on genetics. We can't really do much, at least at this point in time, to change that. Socioeconomic factors is another thing that's very difficult and we can have really very minimal influence on in terms of the healthcare delivery level. Things we can control, of course, are unhealthy habits: smoking, alcohol, sugar, fat, stress, and I'll speak a little bit more about stress in a moment, and depression, and I'll also speak about that a little bit more. Sleep, exercise, and relationship. These are all things that we can address with our patients and help them to foster better habits and better interventions with whatever resources that we can tap for that. So let's talk for a little bit about stress. Stress comes in both acute and chronic forms. Acute forms of stress, the archetype is peripartum cardiomyopathy. That's an acute physical stress. It's caused by the interactions of prolactin cleavage and affects the development of cytokines, which causes myocardial injury. About 2/3 of, or a little bit more, of women that develop postpartum cardiomyopathy resolve it, but some are left with permanent disabilities. But it is a classic example of acute physical stress. Acute mental stress, we see a problem called Takotsubo syndrome, which is in Japan they capture octopuses by putting food in one end of a jar, and the octopus tries to reach in and grab the food, and it gets stuck, so that the jar is fixed at one size, and then the octopus's body is bulbous. And most frequently it's seen in women, but it does occur occasionally in men. That type of image, and it mimics acute myocardial infarction. We see ST elevation. When we take a picture of the function of the heart, it looks like an octopus in the jar. There's one segment that looks dead, but the coronary arteries are normal. And these almost uniformly, these people all recover. But it's felt to be due to acute emotional stress or acute anxiety as the underlying cause. There was a study done back in 1958 that looked at about 1,000 accountants around the United States. Part of it was done in San Francisco. And they studied their blood pressure and their cholesterol throughout the year. And as you might expect, between January and April, all of them developed significant hypertension, and there was a significant increase in serum cholesterol, even though they didn't really change in these individuals who followed their dietary habits. So that's another example of acute mental stress. PTSD we talked about, and then general chronic stress all contributes. The physiology of stress is really a direct on the coronary arteries, affects the vascular endothelium. It's the interplay between cortisol and prostacyclin. Prostacyclin is a arterial dilator. The level of adrenergic state, a stimulation of macrophage activity and inflammatory response, which helps in accelerating plaque formation and also aggravating plaque that's present that leads to thrombosis and vascular dissection. And impaired nitric oxide vasodilation. Indirect effects include just the aggravation of risk factors, including smoking, alcohol consumption, not following as careful a diet, which leads to elevation in cholesterol and blood sugar. So let's switch gears just for a moment to depression. Again, something for all of us to be very sensitive to in our patients with identified cardiovascular disease, or who we feel are at risk for cardiovascular disease. The prevalence of depression after coronary bypass surgery is on the range of 20 to 40%. Does this impact mortality? Yeah, it does, significantly. One study, the cardiovascular health study, took 5,000 patients aged 65, men and women, followed them for 6 years and looked at their mortality risk with depression. Those who, the control group, who had the surgery but did not have depression, had about an 18% mortality risk. Those with depression had a 24% mortality risk, and that was of significance. The EPIC Norfolk study looked at 19,000 patients who had undergone bypass surgery and who had depression, and there was a 2.7 times greater risk of cardiovascular death in those individuals. So it's significant. So how do we reduce stress? How do you guide your patients about this? Well, one of the most important things is social integration. This is one of the examples that we've learned from cardiac rehabilitation. Part of cardiac rehabilitation is social integration, being amongst people who've had like problems as you, being around people that are caring for you, nurses and technicians that are interested, checking your blood pressure, guiding you about exercise. And so that's an important part in trying to have our patients integrate back into their family, into their workplace, into their usual activities will help with stress reduction. More formalized things that we can guide our patients to includes guided imaging to help reduce whatever traumatic effect an event that they've gone through might have had on them. Something that I think is available, especially in our northern California area, is meditation. This was very popular back in the 60s. The Beatles made it popular, but then it kind of went out of popularity in the general population. There's still many practitioners of meditation, as you all know, but the effectiveness in terms of stress reduction, blood pressure reduction, and overall improved cardiovascular wellness, it's becoming more prominent again. And there have been some very good recent studies that have come out to show that. And there's different types of meditation. The most common type you're aware of is Ayurvedic and transcendental meditation, which is sort of a form of Ayurvedic. As it turns out that this can make a substantive difference, and this is something you can think about recommending to your patients, and maybe looking in your own communities to find practitioners that you can direct your patients to. I know some of you are saying, I can't believe he's saying that. Is he saying that? I am. I really, looking at the data, I think it works. Physical exertion, of course, and then sleep. And we have now a lot of professional help that we can send our patients to help with sleep management. So, again, the professionals can help us when we've run out of our own ideas and abilities to take care of people. And think of the Center for Wellbeing as a resource for all of you, and including those of you that are out of the Santa Rosa area, because certainly the center can serve just as a one-time resource to help sort of put a package together and aid in what you're trying to do with your patients. Here's some recommended reading. These are two books on stress that I've found particularly helpful as I've kind of researched this and tried to find some guidance. One is the Mayo Clinic Guide to Stress-Free Living by Amit Sood and the Mayo Clinic, and the other is Stress Reduction 101 by the author Stephanie Roberts. These are available on Amazon and in other places, and are quite good books. I haven't said a whole lot about diet. Probably the hardest question that a patient asks me is, well, doctor, what should I do with my diet now? So that's at the end of that 15-minute visit when I've already covered 12 other things, and I have to talk to them about that. My office is very near Ishiro Nakai's office, and I hear him telling patients about diet, and I'm envious because he's got this spiel. He just takes off, but it takes him about 15 minutes, and that doesn't work out. So again, this is where professional guidance can help, and I think it is important to try and get our patients on board with that as much as possible. There are some very good books, and one of the long-term sort of foundation books is the New American Heart Association Cookbook. It originally came out as the New American Diet, but it's in its 8th edition, and it's extremely well written and very practical, and any of your patients could pick this up. It's not expensive, and if they just read the foreword and the first 2 chapters, they will get an excellent outline for the type of diet that might help them. Also, some of the grocery store chains promote these visits where they'll have somebody take patients through the store and show them how to read sodium contents on the various types of foods, how to read sugar content. And I know Safeway does that here in Santa Rosa at 2 different locations, and I'm sure many of the other stores in our region do the same thing. So that's something you can find out about and give that information to your patients. So here's the interaction of our patients, receiving tender care from our nurses, exercising together. That social interaction helping their peer group, happy patients exercising, enjoying the day, and interacting. Thanks very much. Any questions? Yes, Tim.
Tom, I missed a little bit on high blood pressure targets. With Sprint coming out, it kind of goes against some of the GNC8 and that sort of stuff. I missed what you said about that. Can you repeat that?
Sure. Those are 2 recent studies that built on the recommendations you're talking about, and it looked at blood pressure modification in patients who were at high risk. And it was based on the criteria of, what's possible with medical therapy on an outpatient basis. And so those 2 studies used those guidelines that I mentioned, intention to treat at 130 or 140, and basically a 10-point reduction either way. And then looked at outcomes, and they were pretty similar.
The disparity is 150 for GNC8.
That's right.
The disparity is GNC8 is 150, and these other studies, I have not heard organized medicine put the new studies in perspective.
That's why this is all recently new data. Cord and Sprint are both within the last 12 months. Yes?
Tom? Sorry, just one comment about the 2 new studies. One of the things I read about them, and while there was this hesitancy to implement them, is that they use ambulatory blood pressure monitoring as opposed to in-office blood pressure monitoring, which is, we know readings in blood pressure in the office are higher, right? So if you try to drive people down their blood pressure based on the things that you get in the office, you'll probably drive them too low.
Yes, that's true.
Over here.
Tom,
Yes.
2 questions. One, given all the benefits you listed, what accounts for the poor participation rates in cardiac rehab, and do payment policies from private and public insurers have anything to do with that?
Yes, that's one of the problems is how the program is paid for, and even though in our program, which is done through the Center for Well-Being, we do have scholarships, as it were. Cost is one issue. Second issue is just physician referral habits. Even though I think most people have an awareness of it, it's not utilized even by our physician population as much as it should be based on that data. The third thing, that there are additional barriers. Distance is a barrier. Transportation is a barrier. Sometimes patient socioeconomic, educational issues are a barrier. They all add up to do that.
Second question, given that you want to enhance psychosocial behaviors and alleviate depression, what do you tell people about sex?
That it's good.
Do you offer any guidelines at what level of MET oxygen consumption or treadmill behavior, or when is it safe? Is it always safe? Is it
We do,
what criteria?
and the general guideline is if you can walk up a flight of stairs, you can do it. That's the general cardiology guideline. Yes.
I want to get back to blood pressure because I think there's a problem that different groups, professional groups, have different criteria for what constitutes a good blood pressure.
Yes.
And so I was wondering what you've decided in your personal practice.
In terms of a good blood
Numbers.
pressure as a target, or
Target.
A target, yes. Well, there is a bit of controversy about that. I tend to agree with the Accord and the Sprint studies, because they did look at high-risk patients, and they did use MACE, or major adverse cardiac events, as their endpoint. So I believe targeting 140 and maybe even 130 is appropriate. Yes.
Could you comment on plant-based reversal of cardiovascular disease?
You have to say that again, Andy.
Do you have any thoughts as a cardiologist on the plant-based diet as a way to reverse coronary vascular disease?
I don't have any, specific information on that. I wish I could answer your question. You're referring to a diet that's solely vegetarian or vegan, basically. I don't have any specific information on that. I mean, there's been studies that have bounced around for years about plaque reversal, but none of them have ever had enough power in terms of the N and the parameters, at least that I could see, that convinced me that there is reversal with it. I mean, probably the biggest in my lifetime, practice lifetime, Dean Ornish was probably the biggest proponent of it, and I think it kind of lost steam because it never was as evidence-based, well proven as we had all hoped. Plus, it's difficult. It's difficult to push patients in that direction, as you know. Dietary change is one of the hardest things to affect people with. One more?
Dr. Dunlap, hi. Dr. Nicuzzi, you talked about the stress cardiomyopathy. Can you elaborate a little bit about stress cardiomyopathy? Is a recent diagnosis. What are the diagnostic criteria and the exclusion criteria for such a condition? And have you seen any?
Well, for the Takotsubo syndrome or stress-induced cardiomyopathy, the diagnostic criteria is an event that mimics ST elevation myocardial infarction and the results of an angiogram that demonstrates normal coronary arteries. So that's how you make the diagnosis. The treatment is medical therapy initially, with the usual medications that we use in patients that have left ventricular dysfunction in the setting of myocardial infarction. Beta blockers, ACE inhibitors, we treat them with aspirin. And if they have the risk of dyslipidemia, we treat their lipids. I'll make one further comment that we, just about some of the earlier talks, in the stroke talk, they talked about the effect of atorvastatin on reducing the incidence of stroke. And we also believe that the cardiologists also believe that atorvastatin has a direct anti-inflammatory effect and plaque stabilizing effect on patients with coronary disease. In fact, it's one of the tenets of our treatment program in people that present with myocardial infarction is high dose or 80 milligrams of atorvastatin. So, all right. Thank you for your attention.